These experts will also provide an update on anti-vaping and anti-smoking initiatives and resources we providers can utilize for our minority children and adolescents. So let's get started. We will have 2 of the 3 panelists speak first, and then there will be a question and answer period. Afterward, we will have our final panelist speak, with another period for questions and answers. If you have a question for a panelist, please type it in the box you see to the right of your screen. And please be specific if your question is for a certain panelist or all the panelists. We will try to address as many questions as possible during this webinar, but please note we may not get to them all. Our first speaker is Dr. Garth Graham, the Vice President of Community Health for CVS Health. A cardiologist and professor of medicine, Dr. Graham is a leading authority on social determinants of health and health inequity, and leads strategies on these aspects throughout CVS Health's many businesses across the country. He previously served as Deputy Assistant Secretary at the U.S. Department of Health and Human Services under both the Bush and Obama administrations, and directed the development of the first National Health Disparities Plan released under the Obama administration. Dr. Graham contributes to several boards and is featured in various media outlets, as listed in his biography highlighted on this slide. And today we are grateful he has taken the time to speak on our panel. Welcome, Dr. Garth Graham.
Good morning, and thank you for having me. You know, as we start this panel and as we start this conversation, America has officially become the epicenter of the COVID-19 epidemic. This morning, deaths from the virus reached to 19,563 in the United States after New York just reported 783 new fatalities. And we have officially passed Italy as the epicenter, and now the United States is in fact the epicenter of the COVID epidemic. I think it's a challenging statistic. It is a very real issue, and it has shown how quickly things have changed just in this past month, not to mention how things have just changed over the past couple of months, both for our country and the world writ large. As we have this conversation, we know that there are numbers that are changing in particular communities that have a high number of African American as well as Hispanic citizens. What's interesting as we see this play out is we see not only a disproportionate impact in terms of what's happening within minority communities, but we're seeing where our data is not exactly catching up in terms of what we need to know to understand fully the epidemic nationally and its impact on minority communities. One of the things we do know is despite the heavy toll that this is taking in the United States and the way it's taking in terms of much of Europe, we do know that things like testing and social distancing and all the phrases and terminologies that we've all been hearing about and repeating in various public health settings, we do know that those things work. And so it's important for us to understand. Could you speak a little closer
to your microphone, please?
Oh, yeah. Can you hear me now?
A little closer. Much better. Thank you.
Is this better? Oh, great. I'm sorry. Yes. Thank you. It's important for us to understand just how important communications like these and how we engage both the NMA as an organization, but as well as the NMA members on the front lines of this fight. As many of you, and you'll hear more about this during the conversation that we have today, when we start to look at specific areas such as Milwaukee County, where we know that about 26% of the population in Milwaukee County, Wisconsin, is Black. African Americans make up about half of the cases that we're seeing within Milwaukee County and about 81% of its deaths. In Chicago, Illinois, over 70% of those who have died so far are African Americans, despite the fact that the African Americans make up only 30% of the city's population. Louisiana, as you know, has fast also become one of the centers of the epidemic within the United States. And so far, slightly more than 70% of the coronavirus deaths in that state are African American. Similarly, in Detroit, where we see a heavy concentration of COVID-19 cases, and we see where there are almost 80% of the individuals being affected in Detroit are in fact of African American background. So by far as the epidemic has evolved to have the United States serve as its epicenter, we're also seeing where minority communities are not only being disproportionately impacted, but are far becoming the death rate is far becoming, it's hard taking a heavier toll, particularly on these communities. So part of my role here this morning was to set the stage for further conversations you're going to hear in terms of COVID epidemic, but also what we know about vaping and what vaping does to lung pathology and how that pathology sets the stage potentially for morbidity and mortality related to COVID. What's more important, I think, is also talking about how we engage the NMA, as well as the many vibrant members of the NMA who are on the front lines in this epidemic and who are interacting with many of these communities and are leaders in these communities from New Orleans to Detroit to Philadelphia to Washington, D.C., on all of the places that are becoming epicenters across the board. I think as we see it, we see the NMA as being on the front lines, and I think working with the NMA both currently what we're doing here in related to vaping, but also evolving our efforts to impact the COVID epidemic is going to be vital when we look back at how we responded and what we did. From the CVS Health standpoint, we have stood up a number of high output testing centers in various locations across the United States. Most recently, we have set up locations in Massachusetts, Rhode Island, and in Georgia at Georgia Tech. In addition, we are working with the government in Louisiana and have set up testing sites there and also providing direct support within the convention center as they have stood up additional healthcare facilities there. So we're there on the front line along with our colleagues from the NMA and other folks who are on those front lines dealing with this particular pandemic. What we want to do and what we're thinking as we work with the NMA is twofold in terms of the overall strategy. We understand the importance of testing, and I think as we continue to set up more testing sites, we want to work with the NMA to direct and make sure our communities are aware of those testing sites. We're seeing a lot of high numbers in terms of people passing through these testing sites. So we know that there is generic awareness within the community. We also want to make sure that particularly African American communities are aware of testing sites, whether it be those run by us or run by others, and where they can learn more about symptoms and get better information. So that's one. So we see testing as a priority. The second thing that will be important as we continue this partnership with the NMA and others will be what I call the second wave and even the third wave of this pandemic. We're not sure what might happen in the fall. We may potentially see a resurgence. What we do know is that there's a disproportionate socioeconomic impact that will come with the fallout from the economy related to this and the social determinants of health issues that are going to be a part of what we see in terms of these second and third waves, again, are going to highlight the importance of African American physicians working on the front lines and organizations such as us working closely with those, with you all and with those folks in terms of leadership positions to get at just that. So I won't go on any further beyond this point, but suffice to say that my role here is to talk about the importance of the NMA as an organization that has had a tremendous amount of leadership in this fight against health disparities. Now I think our communities are in the fight of our life, certainly the fight of our generation, if not the fight of our lifetime. And CVS Health, working with the NMA as well as other minority organizations who have reach and tentacles into the community, see ourselves as part of that fight and part of the solution in terms of how we get information to African American and other minority communities that are disproportionately impacted, how we think about this initial first phase in terms of making folks understand the importance of testing, understand locations in terms of testing, as well as understand the importance of other things that they can do to prevent the onset and the morbidity and mortality related to COVID-19. So I'm going to stop there, but suffice to say that we see the NMA as an integral part of both what's happening, both what's supposed to happen currently, as well as addressing some of the longer-term issues when we think about the fallout, both economically and health-wise from this pandemic. I'll stop there.
Thank you so much, Dr. Graham, for reminding us of the importance of NMA and how we can impact and make a big contribution towards our healthcare system and addressing these healthcare disparities, as well as the continued relevance of social determinants of health. Our next speaker is Ms. Laurie Rubiner, the Executive Vice President for Domestic Programs at the Campaign for Tobacco-Free Kids. She has served in numerous leadership positions in Congress and the nonprofit sector, adding up to more than 25 years of experience. These include serving in legislative roles for both Democratic and Republican congressmen, the inaugural director of the Universal Healthcare Program at the New America Foundation, and she is one of the founding board members of the American Constitution Society for Law and Policy. We are grateful you have taken the time to speak on our panel today. Welcome, Ms. Laurie Rubiner.
Thank you. I'm very happy to be here, and let me just get to my slides. Hopefully I'm going to do this right. Okay. Good morning, and thank you very much, and I'm really honored to follow Dr. Graham. I'm very pleased to be part of this panel. CVS has been really a trailblazer in the tobacco control movement, having been one of the first to ban the sale of tobacco products. So it's a real honor to follow him on this panel. And it's really an honor to be part of this webinar with the NMA, which really has been a partner to us in the tobacco control movement and really on the front lines of providing information and really fighting this fight to solve the problem of tobacco addiction. So as soon as the COVID-19 pandemic started, we knew right away that this was a real challenge for us because it's a real teaching moment. And as you all know, because this is a lung illness and the coronavirus attacks the lungs, and we know that we have to seize this moment to make sure that people know that behaviors that weaken the lungs put individuals at greater risk. And it's very important that we get that message out. So at the Campaign for Tobacco-Free Kids, we've been working very hard since the onset of the pandemic to get that message out. There is conclusive evidence that smoking increases the risk for respiratory infections. It weakens the immune system, and it's a major cause of a number of chronic health conditions, such as COPD and other respiratory lung diseases like asthma and heart disease and diabetes. And there is also a growing body of evidence that vaping can also harm lung health. Sorry, I'm having a little bit of trouble here. Let's see. As Dr. Garth said, we are experiencing a tragic, alarming increase in the number of African Americans who are experiencing disproportionate effects of COVID-19. we've seen all over the news an analysis that's finding that counties with majority Black residents have 3 times the rate of infections and nearly 6 times the rate of deaths compared to counties with majority white residents. Many factors could be contributing, including the longstanding structural inequalities of our healthcare system, which you well know. African Americans also have higher rates of chronic diseases such as heart disease and diabetes that make them vulnerable to more serious complications from coronavirus. And we don't know what role, if any, smoking may play, but we do know that that smoking and maybe vaping is a major risk factor for several chronic underlying conditions that make you more vulnerable. What's really critical, and Dr. Garth did reference this, is that we need to gain a better understanding of what is happening with coronavirus in these communities and why. The number of African American deaths or cases is disproportionate to the African American population in each locality. There are lots of factors that could be contributing, but we need to make sure that we understand what is happening in these communities. And so one thing that is good news is that several senators have called for the administration to collect and publish data by race and ethnicity on the coronavirus testing and treatment. And it is incredibly important that we get this data so that we know what interventions are needed to help prevent existing health disparities from getting worse and so that we can save lives. Sorry. Those with pre-existing lung and heart conditions have proven to be the most susceptible to severe and even fatal cases of coronavirus. And there have been a number of stories that have come out about this. The CDC has said that diabetes, lung disease, heart disease, and smoking may increase the risk of heart disease. They have said that underlying health conditions put more people at risk. We've seen lots of different stories along these lines. Sorry, I'm having trouble with my computer. Sorry about that. And there's mounting concern among leading public health organizations and experts that smokers and e-cigarette users may bear a higher risk for severe illness from COVID-19, mainly because it is a virus that attacks the lungs. The coronavirus that causes COVID-19 could be an especially serious threat to those who smoke tobacco or marijuana or vape, and this comes from the U.S. National Institute on Drug Abuse. We also know that tobacco smoking can increase the risk for developing lung disease. I am having computer problems. I apologize. That increasing the risk for developing lung disease, making it harder to recover from COVID-19 infections. The Centers for Disease Control and Prevention has encouraged us to encourage patients to quit smoking and have a Quit Now helpline or visit the CDC website for more information. We also know that e-cigarettes are one of the worst offenders. We have been in the midst of a nationwide youth e-cigarette epidemic with over 5.3 million kids using e-cigarettes. Flavored e-cigarettes and easy access to these products have really fueled this epidemic. In addition to nicotine, youth e-cigarette users inhale harmful substances, including toxic chemicals and metals like nickel and lead. These are part of the e-cigarette epidemic. At the Campaign for Tobacco-Free Kids, our message has been that now is the time to quit. We have been urging all smokers and e-cigarette users to quit in order to protect their health, especially at this critical time. Flavored e-cigarettes are one of the worst ways to addict. Research has shown that quitting smoking rapidly leads to improved lung function. And the US Surgeon General has said that right now, in this moment, it's your day to quit smoking, especially with the COVID-19 pandemic. We have some resources on our Tobacco Free Kids website to help you quit smoking. We encourage everybody to go to our website to use those resources. There's a whole host of ways to help you quit smoking while you're at home. There is no better time right now to protect your lung and lung health. We also urge parents who are home with their kids to have conversation with their kids about smoking and vaping. Sorry, this is not working. I'm having a little trouble with there we go. So one of the things about this period of time is kids are at home with their parents and not at school, which gives the parents a great opportunity to spend some time with their kids talking about smoking and vaping. With the growing concern that smoking and vaping can increase the damage done by COVID-19, this is a great time for parents to spend some time talking to their kids about how important it is to quit, and better yet, never to start using these products. While the kids are at home with their parents and away from social and peer pressure, which often happens at school, to vape, this is a great time to seize the opportunity to educate and help our youth better understand the dangers of vaping and nicotine addiction. We have some tremendous resources on our website at protectkids.org. There are some videos there that can help parents understand how to talk to their kids. There are tips about talking to your kids. There are things that parents need to know with videos and facts about the types of products that are available. There are some videos from teens themselves about how they got addicted, what kinds of peer pressure they're exposed to at school, how they've struggled with the addiction, how to have a conversation with your kids. It's really helpful. So I encourage you as providers and to encourage your patients as they come in to go to our website at protectkids.org. The increased risk the coronavirus poses to smokers and vapers makes it more important than ever for policymakers in cities and states to adopt strong tobacco control measures. As youth in the US are using e-cigarettes at such high rates and are potentially more vulnerable to symptoms of COVID-19, it's especially critical to keep e-cigarettes, cigarettes, and other tobacco products out of the hands of kids by prohibiting all flavored tobacco products. This is one of our main missions at Campaign for Tobacco-Free Kids, both at the state and national level. We have been working on legislation to ban all flavored tobacco products, including flavored e-cigarettes. This will reduce the number of kids who vape and smoke, making it easier for kids and their lungs to stay healthy. We all know that flavored tobacco products are really popular among kids. The growing market is not a coincidence. The tobacco industry knows that flavored tobacco products appeal primarily to youth and new smokers. They have targeted kids with flavors. 8 out of 10 kids who have used a tobacco product started with a flavored product. 81% of youth who have ever used a tobacco product initiated tobacco use with a flavored product. 72% of current youth tobacco users used a flavored tobacco product in the last month. 97% of current youth e-cigarette users have used a flavored e-cigarette in the past month. And almost 71% of youth e-cigarette users say they use e-cigarettes because they come in flavors I like. And 57% of high school e-cigarette users use menthol or mint flavored e-cigarettes. E-cigarettes are the most popular tobacco product among all youth. And while African American youth smoke cigarettes at much lower rates than their white and Hispanic peers, cigars, which are priced cheaper, which are often 2 for 99 cents, are very popular among African American youth. And these cheap cigars come in a wide variety of kid-friendly flavors. And as most of you already know, menthol cigarette use is highest among African Americans and youth smokers. Tobacco companies know that menthol cools and numbs the throat and reduces the harshness of tobacco smoke, making menthol cigarettes more appealing for kids who are starting to smoke and harder to quit. African Americans smoke menthol cigarettes at high rates and quit smoking at lower rates. And the tobacco companies know this, and that's why they've targeted African American communities for years. 85% of African American smokers use menthol cigarettes compared to 29% of white smokers. Over half of youth smokers between the ages of 12 and 17 use menthol cigarettes compared to less than 1/3 of adults ages 26 and over. 7 out of 10 African American youth smokers use menthol cigarettes. This is a consequence of decades of targeted advertising for menthol. It's not an accident. For decades, the tobacco industry has engaged in targeted marketing of menthol cigarettes to African Americans and to youth. The targeting continues today, and it's a travesty. Ending the sale of menthol cigarettes is one of the most important steps policymakers can take to further reduce youth smoking and address tobacco-related health disparities. This is an example of some of the, I don't know why it just moved, but this is an example of some of the marketing that the tobacco companies have done for menthol cigarettes to the African American communities for years. There are lots of opportunities for action coming up. The FDA has put out a guidance in January that would restrict flavors in e-cigarettes in some pre-filled products, leaving countless flavored e-cigarette products widely available. It falls well short of what is needed. In November 2018, FDA proposed prohibiting menthol cigarettes and flavored cigars, but there has been no movement on that issue since then. On the federal level, by passing the Reversing the Youth Tobacco Epidemic Act, this marked the first time that a House of Congress has voted to prohibit all flavored tobacco products, including flavored e-cigarettes, flavored cigars, and menthol cigarettes. In prohibiting flavored products, we think it is important to include funding and programs to help smokers quit. And we have been working in the states. Over 250 localities have restricted the sale of flavored tobacco products, and over 80 of these include the ban on menthol cigarettes. The NMA has been a tremendous partner and is fully supportive of prohibiting all flavored tobacco products. We really look forward to this continued partnership. So just in closing, I just want to say that the COVID-19 pandemic is a really important, it's a tragedy, but it is an important moment for us to remind people that smoking and vaping are contributing factors to much more severe illness. And I hope that we can continue to work together to ensure that people are reminded that these are not behaviors that don't have consequences. And we really are very grateful for your continued advocacy to ban smoking and vaping. And thank you very much for including us in this presentation. I apologize for the technical glitches. Thank you.
It's no problem, Ms. Rubiner. Thank you so much for great information on vaping and smoking and how it relates to the African American population and how we need to be agents of change on this important issue. Now it's time for our first question and answer period. Again, if you have a question, please do not forget to write it in the box to the right of your screen. We will try to address as many questions as possible. And we thank you for those who already started submitting questions, because we already have a few. So let's get started. The first question is for Dr. Garth Graham, and I think this can, Dr. Graham, can be a continuation of you setting the stage for continued discussion. Are African Americans more likely to contract COVID or more likely to die from it?
It's an excellent question. I mean, we definitely can tell via some of the early preliminary data that the death rate appears to be higher within African Americans in general. The issue of whether we're contracting at a higher rate, again, depends on whether we as a country understand what our true baseline infection rate is. And part of the challenge with that is that we know there are a number of asymptomatic individuals who are, may either develop mild symptoms or asymptomatic, no symptoms, or have developed mild symptoms. And so we really don't have a good handle as a country in terms of what the generic overall prevalence and, in fact, potentially incidence rate is of COVID, COVID-19 particularly, because of not knowing what's happening in those individuals who have a lack of symptoms. So the one thing we can tell so far is that the actual death rate appears to be higher within the African American community. We've been having a lot of these conversations with, clinicians and, all of the various parties across the country as we all have been kind of engaged in this. And one of the things is there's a lot of unknowns. As the data unfolds, there are things that we are learning about that we may not even have known a couple of days to weeks ago. So this new, so the thing that I think will give us more information will be the antibody testing, in particular the IgM and IgG antibody testing, because that'll give us a better concept of what the baseline is for people who may have recovered and not have symptoms, and give us a truer kind of incidence and prevalence rate overall. But one thing we definitely know is that the death rate appears to be higher. Lori made an interesting point around data and kind of things that around data collection and around some of the pushes that people have been making to encourage the government to start reporting out data and encouraging all the various parties to really come together on this data issue. Until we have a true picture of the data, we won't be able to really answer questions like that one you just asked, when in fact I think the question that was just asked is pivotal to really understanding the true impact of this epidemic. But again, we just don't have the full breadth of data to be able to answer that conclusively.
Thank you, Dr. Graham. I have a question now for Ms. Rubiner. And the person who asked this question definitely thanks you for addressing this important public health issue on vaping, particularly as it burdens communities of color. Are there any national policy strategies to apply pressure against vaping manufacturers? And if not, do you see this as a viable strategy?
I think that thank you for that question. We've been really working hard to shed a light on some of the practices of the vaping manufacturers and the vape stores themselves, because they have really been successful at portraying themselves, for example, as sort of just good community actors. And so, for example, one of the things that they were trying to do when the COVID pandemic started was to get themselves designated as essential businesses so that they could remain open. And we worked very hard, both here, both nationally and in the States, to point out that entities like vaping shops that are selling products that are actually part of the problem and not part of the solution should not be designated as essential businesses. And in some cases we were successful, and in others we were not. But so I think we also want the PMTA review at FDA to prove that they are actually good for public health, something that they have delayed and really fought against. And this is part of the FDA review. So we really hope we can, and that this FDA review, it's very arcane and it's hard to explain to the public, but this is a very critical piece of trying to get the vaping industry to comply with what is actually, what should be on the market. So we look forward to working with NMA and other really critical partners to ensuring that there is a rigorous review of these products, because the standard is they should not be on the market unless they are, unless they can prove that they're good for public health.
Thank you for that, Ms. Rubiner. I want to continue this conversation as a couple more questions came in, very related to what we were just talking about on policy strategies, but now on to legislation. So a couple questions just came through on the House of Representatives bill in terms of the status. And so can you clarify or speak to that?
Sure. So it was a really strong bill, and I cannot underscore how important the leadership of the NMA and some of the other partners were in getting that bill passed, because one of the most difficult parts of that bill was the ban on menthol cigarettes, which many of you may know is the African American community is divided on that provision. We were very supportive of that provision, but we needed help in the African American community, and the NMA was a leader on that. And it was ultimately included in the bill, but not without a lot of, it was one of the sticking points in the bill. Over 80% of the CBC, the Congressional Black Caucus, ended up voting for it, but that was largely because of leadership of organizations like the NMA. And so that bill passed the House. I'm forgetting, it feels like I've completely lost sense of track of time, but it was about a month ago that that bill passed. And that was a watershed moment for us. We've never had, it passed February 28th. And that was a watershed moment for us. We've never had such an expansive bill that banned all flavored products, including menthol cigarettes. Unfortunately, it does not have any chance of passage in the makeup of this Senate, because it's a Republican Senate and led by Mitch McConnell. However, we are continuing to push and lay the groundwork in the hopes that we will have a change in leadership in the Senate and in the White House, so that we can have that bill brought up next year, and with a change. We also, as I said, as I mentioned, are leading efforts all over the country, trying to get similar bills passed, and we hope to be able to do that. The menthol issue is a very difficult issue, and it is very divisive in the African American community. So that is one that we have to continue to work on. And the leadership of the NMA has been critical in that.
Thank you for clarifying that. We're going to come back to that, but I also want to bring Dr. Graham in, because a few questions also came in on testing. And Dr. Graham, you can cross-cut with this. So a couple questions relate to testing sites, that there are epicenters noted in a couple places, but is there a plan for more testing sites in specific areas targeted and specifically where we live? So Chicago, Detroit, Milwaukee. And then I'm going to double load you that there's surprisingly high rates of false negatives early in disease from one person.
Yep.
And that person's afraid that encouraged testing will lead to a false sense of security in people who are sick and cause them to relax their isolation efforts, leading to further spread. So this person wonders if it's more prudent to withhold testing and continue to urge people to isolate.
Well, and we need to do testing to get a true. I get where the question is going. Actually, that's a very thoughtful question, because the idea is, do we in having a higher false negative rate, do we create a sense of security? Well, part of it is we still tell people that even if they test negative, to continue to observe all of the various both social precautions as well as clinical precautions in terms of washing your hands, understanding how to interact with high-risk individuals and potentially may transmit the disease. Just because even if you are a true negative today, doesn't mean that you sustain that negativity if you have ill-advised exposures, because you can certainly then contract the disease, in the next day or the day following, etc. The funny thing that is coming out is now, as some of you may have seen, in South Korea, where people who have been thought to have been acquired the disease, got over it, and then now appear to be potentially testing positive again. And the question there again is the reliability of the testing and whether those are true positives versus false positives. And the issue again, as well as whether, that infectious process really took its full toll. That's why I think the issue around antibody testing, which many of you have heard the federal government say is really about to come online in the next week or two, is going to be particularly important, because understanding whether somebody genuinely had developed antibodies to the disease is important. And so to answer the question more succinctly, I would say that testing is still continues to be important. My advice would be, from a clinical context, is that even if somebody was to test negative, their behavior patterns should not change, because that does not insulate them from acquiring the disease even later on that day, or even in any kind of quick time period. So whatever your testing status should not defer or give you any false sense of immunity in terms of being able to behave appropriately. So that's one. The first part, going to the first question is, yes, we're actively working, and you'll see this as part of how we articulate messaging with the NMA partnership. And that's why this partnership we're developing with the NMA is so important, because as we unroll and as more testing sites come online this week, we have some, and then following week, and as the things continue to unfold, getting the word out to African American communities is pivotal. It is going to be pivotal, because one of the things about testing, and those of you who've been kind of in this arena with us and others over the last couple of weeks to months, is that understanding that within families, that most of a vast majority of the transmission is happening within families. So it may be somebody who has to work at a grocery store because they're an essential worker in that context, and they may contract the disease and may not know, or may have mild symptoms, or etc. They may then be interacting with an elderly family member who then may develop more severe disease. And so being able to kind of test and identify within these communities is going to be important. And it's the only way we're really ever going to get out of the issue of even being able to relax a lot of the social and other mandates we have in terms of putting the economy back online. So yes, so to answer that first question again, we are planning future testing sites, many within all of those urban locations that you just pointed to, and working with the NMA to get the message out. So I think stay tuned to our partnership with the NMA as we evolve around educating our communities. The last thing I'll say is one of the things that has been mentioned, but I don't know if we have a lot of data around this, is whether there may be myths and misconceptions that are becoming more prevalent within the African American community that might deter either safe activities or testing. I've not seen any true qualitative data published on this. Just kind of, we've heard anecdotally about different things along those lines. So getting the right information out to our communities through the NMA and other leaders is going to be particularly important.
Thank you for that. I have another question that I'm going to address to both of you. This is a combination out of several questions that have come in. Of course, President Brooks and I are pediatrics based, but where is the data? And I'll clarify, can you speak more to the data on the elderly, on those with sickle cell, does that data even exist in terms of vaping and compared to our population versus other populations?
Do you mean in terms of vaping and its impact on the elderly, or COVID vaping and the elderly?
However you want to answer that, both will work.
I'm a little unclear. Dr. Graham, do you want to go first?
Yeah. I'll jump in on the COVID and the data on the elderly and higher risk. Many of you know the data. A lot of the data around how we've been categorizing those with higher death rates came out of initially Wuhan, China, where a lot of the earlier epidemiologic studies that have guided how we approach this pandemic has been generated. And so what you saw there is a much higher death rate skewed towards people with specific comorbid illnesses, as well as the elderly population described in that context of being over the age, those being over a certain age. What you have seen, though, is even within the data that has come out of Italy, the death rate does continue to be higher within those pre-described populations, but with some variation in that context. I have not seen any data around sickle cell, and I can assume that's because the prevalence of sickle cell within most of those prior epicenters is probably on the lower end, given the demographics that normally accompany the prevalence of sickle cell in general. There is data around asthma, and I think that goes along with the some of the things that we kind of articulated, that Lauren kind of articulated earlier, around the sensitivity around lungs to COVID in general. So I would say that most of the data we have so far have come out of Wuhan, a lot coming out of Europe, and then now, just literally now, I think we're starting to generate a lot of our own data in terms of some of the series studies that have been published in the New England Journal and JAMA just over the last couple of weeks. In a smaller series, but still enough to identify and co-sign what I think we saw with some of the earlier data from Wuhan.
Yeah. So I guess we specialize in youth use of products, so I can't speak to any data on elderly, but we have, and there's not enough data on vaping because it's a relatively new phenomenon, but we of course know that smoking leads to chronic respiratory issues and weakens the immune system and causes chronic health conditions. And the hope is that this pandemic is coming at a time when vaping is much more popular. And that's why the data collection is so important, because this is our one opportunity to really gather the data on how many of these people, particularly young people who are experiencing severe chronic, who are experiencing severe illness from COVID-19, have they been vaping? And that's why it's so important to collect this data. And it's especially critical in the context also of health disparities to find out, is there a link in the African American community where the health disparities are so high? What is the link between some of these health disparities and smoking, so that we can then educate and increase our advocacy around how important it is to quit smoking and get cessation resources to those communities.
Okay, thank you both for addressing that. There are so many more questions coming in. You guys are doing great. To the audience, you all are amazing. there was one question, and there's a couple questions, and I'll direct this to Ms. Laurie. Can you speak to specifically how the Campaign for Tobacco-Free Kids, your strategy on outreach, can you go a little further? Because we know the aggressive lobbying by all the other companies, specifically as it applies to vaping with non-tobacco products that can be put into vaping devices.
With non-tobacco products, do you mean marijuana?
As an example, sure. Or others, yes.
I mean, I don't know what you mean other than non-tobacco. I mean, we work really only on tobacco products. So, you know, we don't work on marijuana, though there has been a lot of the lung injuries that we read about months ago. The tie to those was largely from illegal products and THC, but we focus only on legal products. Now, what I will say is, you know, we also, some of those products that are legal are being sold, you know, kids are not supposed to be buying them. And so a lot of what we focus on is the illegal sale of those products to kids who are underage. And so, but we also focus on the marketing to kids of products that are hooking a whole new generation of kids to nicotine who would otherwise not have smoked. But if the question you're asking is, do we focus on things other than nicotine addiction? You know, we don't. We only focus on nicotine products. We have not gotten into. We don't focus on marijuana, though that is a, you know, that's a whole problem in and of itself. Which, by the way, big tobacco is part and parcel of the new marijuana industry, as you probably know.
So then to add on, because another person asked this other question, to reach out to predominantly minority communities, what are other volunteer partners or organizations you can work with to further the agenda of Campaign for Tobacco for Free Kids, but also address and truly address those concerns? Because I believe it is more than tobacco that is affecting our community, that could still play a role in our pre-existing lung diseases and then other conditions which COVID-19 can influence us. Is there a possibility of working with other organizations and of course us, the NMA, in addressing this concern?
I guess, you know, we have been working with a number of really great organizations, the Urban League. So in combating lobbying dollars from the industry, we rely on a coalition of many different constituents, including the African American community, the NMA. We've been working with the NAACP, the Black Women's Health Imperative, the Hispanic Medical Association, the Association of Black Cardiologists, the National Dental Association. We've been working with a whole host, the Urban League, a whole host of organizations who have been absolutely critical in this fight. The National African American Tobacco Prevention Network. It has been, as they say, it takes a village. And this group of people who have come together have really been elevating the voices of the minority community in this fight against tobacco and nicotine addiction writ large. But it has been focused on tobacco and flavored tobacco products. We have not strayed into the other issues. There are a host of other issues, and I don't disagree. There's lots of other issues that contribute to lung damage, etc. But those are not issues that we have. We have focused only on those, on the legal products that may be, by the way, again, sold illegally to children. But we have stayed in that lane. because that's how we were formed and that's the focus that we have. I agree with you, Dr. Walton, that, you know, the problem is that these implements, these vaping products, particularly the open tank systems, make themselves available to other illegal products and, you know, like marijuana and THC. And that is a problem, but it is not one that we have yet taken on because there's a whole other legal body that deals with the regulation of marijuana that is not what we work on. We are in touch with them and we talk to them and we recognize, but that's a whole other set of issues, as you well know.
Understood. No, I understand where you're coming from. So I have one more question, and that's to Dr. Graham. To build on this, I would love for you, Dr. Graham, to speak on building on from what we've talked about in terms of vaping and other other substances, particularly towards our population, but then add on as well from another colleague that also had a question for you as a cardiologist. They're seeing that doctors are on the front line of COVID-19 are seeing patients with heart damage and dying of cardiac arrest as well as respiratory symptoms. They were interested in your thoughts on that as well.
So it's interesting. We're seeing a couple of things. We're seeing patients who look like they may have maybe some like a myocarditis, inflammatory type picture. But more importantly, we're seeing a lot of people who are just arresting, particularly in the emergency room, whether that be just flat out, you know, VF or VT, ventricular tachycardia, ventricular fibrillation. We're seeing a lot of that, particularly out of some of the earlier reports that are coming out of New York City. What's not clear to me is, you know, many times cardiac arrest is the result of another process, right? So if you are acutely hypoxic, and those of us in I practice, so I'll just say, you know, practicing, you know that many times somebody can become acutely hypoxic or acutely hyperkalemic or acutely something else, and that itself leads to a cardiac arrest. So the question to some degree is, you know, is the lung pathology or the other kind of metabolic derangements that's driven by, you know, this acute and then very hyperacute illness, you know, is that causing cardiac arrest as it would in any other case, or is there, you know, a primary cardiac issue that is driving that? And, you know, I guess until we have, you know, not to be morbid, a lot of autopsy data, in particular in the coronaries of people who are passing away in that context, it'd be hard to tell. But I think for me, what's not clear is, again, is it, you know, severe hypoxia that is causing somebody to, you know, have lack of oxygenation and then driving them into cardiac arrest, or is it primary cardiac arrest? And much like much of, you know, when we fill out, I don't know if you, this again sounds very morbid, but a lot of times when you fill out death certificates on patients, it says something like, yeah, you say that if you put number 1 as cardiac arrest, you have to put number 2 and 3 as, you know, what caused the cardiac arrest. And so that's why, again, it's not clear to me whether cardiac arrest is the primary issue or is it secondary related to just the burden of the acute illness. And then again, because some people are, you know, as we've seen in a couple of cases, some people look, you know, relatively stable at 1 p.m. and then by 2:30 p.m. are coding and are hypoxic and are just, you know, acutely going on hill. And again, it's not clear how what's driven, whether it's the heart first or the lungs first, or the lungs affecting something else, and then that's affecting the heart as well.
Thank you, Dr. Graham. Thank you, Ms. Rubiner, and thank you both. We have to conclude our first question and answer period, and I definitely want to thank the audience for some great questions. Some of your questions I did note are actually great for the next speaker, our final speaker, Ms. Megan Jacobs. Ms. Jacobs is the Managing Director of Product for the Innovation Center at Truth Initiative. She currently oversees the management of the Become an X platform and the development of the X Program Enterprise product. Ms. Jacobs is invited to speak frequently at various conferences and in numerous media outlets. As an expert in product design and her passion promoting healthy behavior change, it is evident her desire is to help whomever she can to successfully break free from an addiction. Welcome, Ms. Megan Jacobs.
Hi, thank you so much for having me here today. I'm here to talk today specifically about e-cigarette cessation for teens and young adults, a topic I know is central to many of your work right now. To give you some background context, many of you may be familiar with Truth Initiative as a nonprofit public health organization that's exclusively focused on tobacco prevention and cessation. We were established back in 1999 out of the Master Settlement Agreement between the states and the tobacco industry. And probably most of you who know Truth Initiative are familiar with us mostly through our massive youth prevention Truth campaign, which has really dominated the conversation around youth tobacco prevention. But you may not also know that we do a number of other different initiatives, including design and develop digital cessation programs. We offer a number of different programs to help people of all ages quit tobacco, including Become an X and the X program, which are our adult cessation programs addressing all types of tobacco. And most recently, This is Quitting, which is our program designed specifically to help youth and young adults quit vaping. I want to start today with some background on the state of the science around what else is out there regarding e-cigarette cessation, specifically for young people. We've all heard a lot about the statistics of how many young people are vaping and what the uptake has been over the past few years. But what we hear less about is how many young people want to quit vaping. The 2019 NYTS National Youth Tobacco Survey data showed that nearly 60% of young people tried quitting tobacco in the past year. Now, granted, this question did not separate out different types of tobacco, but we know that among youth tobacco users, the gross majority of that is e-cigarette users. And research that Truth Initiative conducted in the past year showed that over half of young people who vape were considering quitting vaping as their New Year's resolution, and almost 60% wanted to quit in the next year. So we know that that demand is there for young people to quit. We also know that among adults, the data is more clear that e-cigarette users specifically want to quit e-cigarettes, and a little over a quarter have made a past year quit attempt. Many adult tobacco users started vaping as a transition from smoking, as a way to quit smoking, and are now looking for ways to quit. And so it's not surprising that we see that these adult data pretty much mirror for e-cigarette cessation demand what most general tobacco use looks like. And so we would presume that among young people, it probably holds true as well. Unfortunately, the science around what works to help people quit vaping has lagged pretty considerably behind the prevention literature. For much of the first few years of the e-cigarette epidemic, all of the research was focused on youth prevention, understandably so. Unfortunately, now the toothpaste is a bit out of the tube on that, where over a third of young people have already started vaping and are looking for evidence-based ways to quit, and unfortunately coming up short in their search. There are only a handful of e-cigarette specific cessation programs that have been designed and launched. One is called My Life, My Quit. It's offered through National Jewish Health as part of their Quitline services through the states in which National Jewish works. Another is through the American Lung Association called Not on Tobacco, which has historically been a smoking cessation program that just recently evolved to include vaping cessation. This is an in-person delivered program through schools. In-Depth is also offered through American Lung Association, specifically as a disciplinary action program. It is an alternative to nicotine suspension or citation for young people in school. So it's not really a program that's designed to be taken up by young people who just want to quit of their own volition. American Lung Association also offers some resources and conversation guides specifically for parents, which I should note that our Become an X resource does as well. Finally, Smoke-Free Teen, which is one of the resources offered through National Cancer Institute's very comprehensive smokefree.gov, recently expanded to include some online resources around quitting vaping. It's not really a comprehensive program, but more a set of informational resources, and they also offer some live chat that may be able to address young people's questions. So back in fall of 2018, my team and I were noticing that more and more young people were talking about quitting vaping online, asking questions like, has anyone quit before? How did you do it? Does anyone know how to quit? Or where can I find something to help me quit vaping? And of course, they weren't really finding anything specific because at that point, actually nothing had been designed yet. And so my team started undertaking more and more formative research, talking to young people specifically about what their experience was like vaping and trying to quit, to essentially inform a quitting program that would speak to the lived experience of young people. We learned a few key elements that I want to share with you today because I think they'll inform your practice when you're speaking with young people about vaping or quitting. The first is that terminology really matters. So we heard loud and clear from young people that the way they talk about vaping is often very specific. For example, young people who use Juul will often refer to the behavior as juuling. And if you ask them if they vape, they'll likely say no. But if you ask them if they Juul, they'll say yes. And so it's important to get the language right because otherwise you may miss from an assessment perspective, whether a young person is actually using an e-cigarette or vaping. And then from a cessation perspective, of course, we want the programs to be as salient as possible. We also learned that young people had really different experiences depending how old they were and also their previous tobacco use history. So a lot of the young adults that we spoke to had either been smokers before or at least had experimented with cigarettes. So they were a little bit more familiar with what to expect when they started quitting. Whereas younger teens or people who had never smoked before were hit like a sack of bricks when they first started quitting because they really didn't know what withdrawal would feel like. They didn't have a vernacular to explain that they were having cravings. They'd never talked about their addiction in that way before. And so those experiences really matter when it comes to guiding young people in their quitting effort. We learned that even if young people had been smokers before, this is a totally different product with different triggers. So for many young people, and obviously the current circumstance changes things a bit, but for many young people, vaping is ubiquitous. It's everywhere around them. It's at school, it's on the bus, it's at sports practice, it's when they're hanging out with friends, it's on social media. It's very unlike smoking, which often had to be done sort of in secret or couldn't be done in the classroom. Vaping is very, very different. And especially right now when so many young people are really more online, even more of the time because they're at home, that social media inundation with vaping, that presence of vaping is still very likely there for them. We heard very clearly from young people that quitting is both isolating and lonely. Many young people don't know anyone who's tried to quit before. They may not feel like they have friends or family who support them in their quitting, and they feel very much outside of the social norm when they go about quitting. We also heard a lot of uncertainty around medication, although there was a general openness to using it, which was surprising given that many young people resist using nicotine replacement therapy or other prescription medication for quitting smoking. But instead, when it came to vaping, a lot of young people seemed very interested in it and very curious about how they would go about using it, how they should use it, how they can access it. And so it would not surprise me to see you all in your practices getting questions from either parents or young people directly about medication for quitting vaping. So the resultant program that emerged out of all this formative research is a program called This Is Quitting. It's theory-based and grounded in best practices, designed to really help people grow their confidence and skills around quitting. It's tailored based on age, as well as product, whether someone uses Juul or something else, as well as a participant's quit date. It's a daily text message program that's fully automated. It's available 24/7, and the message tone and style is really unique. Messages are written in first person, so they're positioned as a supportive, non-judgmental friend that also bring in messages from other users. So we give all of our users the opportunity to add messages to the program. We've received thousands of submissions that my team carefully combs through. Nothing's automatically added to the program, but we intentionally insert submitted messages in ways that make sense. Young people receive a daily message to guide them through their quitting process. It's very, very easy to enroll. Young people just text Ditch Jewel to 88709. We ask them a few quick questions up front, including their first name and how old they are, as well as some other questions to tailor their messages. And then if they're ready, they can set a quit date. If they're not ready to set a quit date, they get daily messages to practice quitting in different ways, build confidence and motivation. And if they are setting a quit date, they get daily messages to prepare them leading up to their quit date for up to 45 days and for 2 months afterwards to stay confident about quitting, resist peer pressure, cope with cravings and withdrawal. We launched this program nationally in mid-January of 2019, and in the past year and a handful of months, we've enrolled a little over 150,000 teens and young adults. On average, we enroll over 500 young people every day, and the gross majority of this enrollment has come through earned and social media. So earned media and word of mouth online, and young people talking directly to each other, as well as through partners of ours who promote the program through their clinical practices or through their school districts. And recently, in January of this year, we started promoting it through the Truth campaign. And I'll talk some more at the end about how promotion works. Observationally, we are seeing that young people are extremely engaged in this program. About 70% of our users set a quit date, signaling really strong motivation to quit and not just simple experimentation. Around 50% of users use these extra support keywords like crave or slip that we make available so that if young people are having a strong craving or dealing with stress, dealing with relapse, they don't have to wait until their next daily scheduled message. And approximately 70% of our users complete the full program, which is really encouraging to us because we hear time and again that, oh, young people won't sign up for a program to quit. Young people won't engage with a program if they do sign up. And what we're seeing is that that's simply not the case. Of course, it's great to see that young people are signing up in droves and that they're engaged, but of course the big question is it working? And the answer for us is yes. We see that after just 2 weeks of using This Is Quitting, over 60% of our users report vaping less or not at all anymore. And at 3 months, which is the farthest endpoint out that we evaluate, we see 31% of our users reporting 7-day abstinence and 19% reporting 30-day abstinence. These numbers meet or exceed all other quit smoking programs that have been developed for young people, and our program remains the only program that has published any data about outcomes. So of all those other programs I mentioned before, I really can't speak to their effectiveness or impact because we just haven't seen the data on them yet. So there's not a lot to compare it to, but when we look to the smoking literature for comparison, we're really, really encouraged by what we see. Our team at Truth Initiative currently has a comparative effectiveness trial underway, a randomized trial of young adults ages 18 to 24. And I wanted to share some deeper data with you, some from a pilot study that we conducted to inform that clinical trial, and also some of the deeper qualitative data to inform your practice for young people, specifically in this time of coronavirus. So one of the questions that we ask young people very early on in the program is what their reason is for quitting. And I've included a citation here at the bottom. For any of you who are members of the Society for Research on Nicotine and Tobacco, my colleague Michael Amato gave a lengthy presentation, more in depth. So if you're interested on this subject, you can find his more data from his session from that conference. So we ask young people their reasons for quitting, and to date have received over 30,000 replies to this question. Our team has gone through and qualitatively analyzed the different types of responses that we see, and I want to share some of them with you here today. Some big themes that we see coming through are that young people don't want to feel addicted. They don't want to be disappointing their family or their friends or their people that they're in relationships with. It's quite tragic how many young people just they hate the way that they feel for vaping. And of course, lots of concerns about health, finances, the way that this honors people in their lives. So this is, young people are really grappling with a lot of bigger issues than just, oh, vaping is bad for you, you shouldn't do it, right? There's a lot more at play here, the way that young people are evaluating themselves, the way that they're judging themselves and seeing themselves as mirrors of their society and their families. Most recently, we've been seeing a lot of young people signing up for the program, specifically with health concerns related to coronavirus and COVID-19. So we're not seeing huge enrollment jumps, but what we are seeing is that among our registering users who are signing up, a good proportion are submitting their reason for quitting as related to their lung health or coronavirus or concerns about the uncertainty of that. I mentioned that we launched this randomized trial, which is the first randomized clinical trial of any quit vaping program, particularly for young people, but of any program. And we're comparing This Is Quitting against an assessment-only control arm. The protocol for this manuscript is now actually published, but you can find that under the clinical trials record listed there at the bottom of the slide. And it was recently published in Journal of Medical Internet Research for anyone who's interested in hearing more about the protocol design for that study. We conducted a pilot of almost 270 young adults to inform the sample size because we truly didn't know what the unassisted quit rate would be among young adults. So we were able to recruit a pilot study fairly quickly. We recruited the entire sample in only 10 days. And I want to just note that this trial population is majority male, a quarter sexual minority, and a little over half reported vaping within 5 minutes after waking up. And so what this points to is actually a bit more balanced population of vapers than we typically see of smokers in clinical trials, which tend to be dominated by white women, and an interesting upswing in young people who identify as a sexual minority group who are willing to participate in research, which we don't always find. That 55% who vape within 5 minutes after waking is a particularly strong indicator of addictedness, and we weren't sure what to expect, but we were unpleasantly surprised how many young people we saw reporting that. Sorry, got one slide ahead of myself here. In terms of their tobacco use characteristics, we see that almost all of them vape daily. A little over half also vape THC. And again, some measures of dependence signal really strong levels of addictedness among young vapers that we weren't sure what to expect. We didn't know how to characterize this population, and the understanding of addictedness of e-cigarettes remains poorly understood. And so we think that this is an important contribution to clinical practice for sure, to understand that many young people are much more addicted than one might assume or think of as like a young people are just experimenting, this is just folly. It's not. The gross majority appear to be vaping daily and quite dependent on their e-cigarette and nicotine. In terms of abstinence, we had about 80% follow-up rate between both arms, and what we see is that using This Is Quitting nearly doubles the abstinence rates, 30-day abstinence reported at 1 month. And we're still in data collection. We just finished the 1 month data collection for the full randomized trial of over 2,600 young adults, and the primary endpoint of the study is a 7-month data collection point. So I want to wrap up today by talking about how you can promote This Is Quitting to the young people in your population or that you work with, or through your own communities in other ways. So I mentioned that Truth is promoting This Is Quitting, which is a big change for the Truth campaign. Historically, the Truth campaign has only focused on use prevention, and now for the first time is talking about cessation. This is a big distinction, and for young people who know and trust and value the Truth brand, this is something that makes it immediately more recognizable to them. We offer free promotional materials available through the Truth Initiative website for download. You can find promotional postcards and posters that you can download and print out to promote for free however you see fit, whether that's through your practice or through your community. And I've listed the URL here on the top right corner of where you can find these promotional resources. And of course, you could go to truthinitiative.org and just search for This Is Quitting. In addition, in response to significant interest from outside groups, we have set up a way to contract with different organizations who want to receive reporting to understand how their particular population is using This Is Quitting and what the uptake and engagement and quitting outcomes are among their young people specifically, as well as promote the program in a co-branded way or customize the program for their young people. So we've stood up mechanisms to be able to do that. And I encourage you to reach out to me directly. My information will be on the last slide here. If that's something that interests you, I'm happy to talk to you about it. We're working with a number of different states, local health departments, hospitals and hospital systems, school districts, basically any type of public health organization or organization who works with young people is working with us in a structured partnership right now. And so I would welcome any questions you have about that or about the program specifically, or about youth or young adult cessation right now. So again, thank you so much for having me. It's been a pleasure being with you here today.
This is great information, Megan. Thank you so much.
My pleasure.
We now have time for our next question and answer period. So we do have some questions here. One question that I actually agree with whoever submitted this question. Can you speak to the cultural sensitivity or are these resources that you have, are they culturally sensitive and crafted specifically for a variety of populations, including the African American population?
So we don't design different promotional materials for different subgroups, but I will say that the team at Truth Initiative who develops the promotional materials for This Is Quitting is the same team that designs the Truth campaign, which has always been very much focused on reflecting a multicultural youth audience, especially understanding that the majority of youth tobacco users are young people of color or of socioeconomic lots of different socioeconomic statuses, including lower education, lower income, sexual minorities, and gender minorities. And so we absolutely keep an eye toward that. And we make sure to include in discussions in program development our team that works in community activism and youth engagement, who has a very strong presence on historically Black colleges and universities and other minority serving institutions to make sure that the language that we're using is inclusive and representative.
Thank you. President Brooks, I believe you have a question?
Yes, so I have a question for Ms. Jacobs and then one for Dr. Graham. Ms. Jacobs, do you see a way to link your activities in terms of quitting now with COVID-19 being a scourge in the country? The kids are now sheltered in place, they're out of school, they're at home, they may have less access to e-cigarettes or any tobacco product. How do you see your positioning right now as it relates to your Truth Initiative activities?
So it's an interesting question because we are seeing some young people saying things like, well, this is a great time to quit because I'm at home and I don't have access to it, so I might as well try quitting. And other young people who are really, really struggling because they don't have access to it, they didn't want to be quitting, and it's much more difficult than they anticipated. And much the same way that we see lots of different substance users who might be imprisoned for long amounts of time, who don't have access to substances, and then the day they get out, go right back to using because they haven't addressed any of the mental or psychosocial aspects of their addiction. That's kind of the same thing that we're seeing right now with vaping, where a lot of young people say, I don't have it, but I'm struggling and I need help to help me cope with those feelings.
Okay.
So I think it's too early. We don't have outcome data yet, though, related to that.
Okay, thank you. So I have a question for Dr. Graham, somewhat unrelated to vaping, the discussion that we just had, and thank you very much, Ms. Jacobs.
Sure.
You mentioned something that I've heard, Dr. Graham, a number of times, and it's that concept of a second wave. So this is a two-part question. Could you just touch on the concept of a second wave? And then if there is a second wave, there'll be more COVID in the news. I'm really concerned about a year from now, the things we've been talking about, the social determinants of health, the fact that vaping leads to respiratory damage and COVID is a respiratory virus. A, the potential for a second wave, and B, how do we not lose the momentum now that social determinants of health, African Americans with disparate rates of underlying disorders, I don't want that to just be buried. So could you address that, please?
Sure. I'll do the first question first. And second question, I think, has a lot to do with, especially this partnership that we've been talking about, the NMA. So the first question. So really, if we don't develop a certain prevalence of antibodies or herd immunity, or, people have developed an actual, like I said, personal immunity to the virus, then there's a very good chance that it behaves like the flu virus in any way, that as it starts to come back, that people will not have immunity and make us very vulnerable for a second wave. I think we're anticipating that around 95% of the population would not have been impacted in the first wave. So that leaves all of those 95% of people susceptible to another wave of infection if the virus behaves in some way like the flu virus and becomes more virulent and more aggressive during the winter months. So I think there is a decent chance, based on, with all the social distancing we've done now, I think that there's a good chance that we'll see, the virus start to die down at some point. But then because we have not developed any immunity to it in that context, it leaves us all very susceptible to it coming back. And that's where the concept of the second wave comes in. But again, truly, I'm not sure we very much know that the virus is going to behave like the flu virus, because it hasn't behaved in that temperature sensitive way that some people had predicted. And I think the National Academy of Medicine report, most recently that came out, just really said it's really not that temperature sensitive as we may have hoped for earlier on. This issue, the second issue around the social determinants of health piece, I think this is a pivotal time. There was a really interesting, when Dr. Fauci first spoke about this at one of the White House briefings, he said something that I think galvanized a lot of people who've been working on disparities. He said, yes, we know that COVID is disproportionately impacting the Black population, but there's nothing we can do about that right now. And I think those comments will serve historically, hopefully, to have galvanized us to say that, well, no, there is something we can do about it right now, and there's something that we can do about it in the future, or be true. And I'm hoping that it is not true, and that there are things that we can do about it right now and in the future. And what I'm hoping is that, and this is also bringing this issue of disparities to a whole new audience who never even knew that disparities existed. And so what I'm hoping is that with partners such as your team, as well as others who've been working on disparities for some time, that we grab the mantle right now, we move forward with the agenda of the kinds of things that we believe can tackle disparities or social determinants of health, and then use this time period to, I think, both educate the public as well as make an impact on our community.
Thank you.
Thank you, Dr. Graham. I appreciate all the questions that are coming in. In addressing a couple of these questions, just to the audience, one of Ms. Rubiner's slides laid out an illustration of the current youth tobacco product use for cigars, cigarettes, and e-cigarettes by white, African American, and Hispanic populations in youth. I'm putting this out there now because to follow up on that question, because a couple more came in, this is for all three of you. Do we know beyond this data that's presented, what is the current prevalence of vaping right now in our communities of color, in youth as well as adults?
This is Lori. Beyond what the slides that I provided here?
Yes.
I mean, this is the most, this is the most current data that we have now. So I don't have any more current data than this. And this is from the 2019 National Youth Tobacco Survey. So this would be the most current that we have. And what's important to note here is that while e-cigarette use is highest among white youth, it's still the most popular. Even though it's lower among African American youth, it's still highly popular among it's still the most popular among African American youth. I think that was the point of showing this, and very popular among Hispanic youth, even though both African American and Hispanic youth use it at lower rates than white youth.
Thank you for that. This next question is for both Ms. Rubiner and Ms. Jacobs. Couple questions have come through in terms of using other resources just for quitting vaping or smoking, such as Chantix. Do we have any data comparing the use of different products? And then specifically for Ms. Jacobs, are the youth in your program notifying you of the brand of vaping product they're using? If so, do you notice a trend in a reduction of Juul versus something else?
I'm
Megan,
happy to.
Go ahead.
Sure. Yeah, I'm happy to speak to that. I'll address the second question first, which is yes, we have young people report what vaping product they use, and we have seen a steady decrease over time in the proportion of our users who report using Juul from its peak at around 70% to now just over 50%. And that uptake has been filled in by not one particular brand, but puff bars are definitely growing in popularity. So that's a disposable e-cigarette that looks very similar to a Juul, but is not intended to be reused and refilled. As for the first question around use of medication for vaping. So as it stands today, all nicotine replacement products and prescription medication like Chantix or Zyban, it is considered off-label use to use them for vaping cessation. So not to say that it can't be done. It's off-label for anyone under 18 to use it, which is it's at the discretion of a provider to write a prescription for it and guide young people how to use it. I have not seen any clinical trial data to guide use of nicotine replacement specifically for vaping cessation, but I will say that the profile of young people that we're seeing in terms of their heaviness of use and their degree of addictiveness looks pretty similar to among people who are interested in quitting, I'll say, looks pretty similar to roughly pack-a-day smokers. So you'll need to all use your discretion, and I encourage you to reach out to the pharmaceutical companies to get their guidance on it as well. But that's what we're seeing. We're definitely hearing from young people that some of them have spoken to their providers and their parents and have gotten prescriptions for nicotine replacement products. So I know that at least some physicians are prescribing it, but I don't know any guidance that's been given from the pharmaceutical companies about how to use it exactly, and it is considered off-label use.
Great,
Yeah,
thank you, Ms. James. Oh, go ahead, Ms. Rubiner, go ahead.
Megan covered it, but the only thing I would add is that the American Academy of Pediatrics is looking at how to provide those resources for youth, since most of the cessation products are being tested for people who are over 18. We don't have a lot of good cessation options for kids. So that's one thing. Could I just take a point of panelist privilege and just go back to the question that Dr. Graham just answered? Because I was struck by the fact that Dr. Fauci said there's nothing we can do. And I didn't hear him say that, and I'm a huge fan of Dr. Fauci, but I do want to just take issue with that because it makes me kind of sad that he would say something like that there's nothing we can do about the health disparities right now, because I think there is so much we can do, even in the midst of this. And, you know, I was just looking at an article this morning about the 4 reasons that, it was in the Washington Post, the 4 reasons that African Americans are being hit so hard by the coronavirus. And, you know, they touched on 4 reasons. One was all the things that we've talked about: higher rates of underlying health conditions, less access to care. But one of them that we haven't talked about, and Black Americans hold a lot of the essential jobs, you know, that one we haven't talked about. But the other one that was insufficient information and getting incorrect information about a lot of this. And this is where, you know, again, the National Medical Association plays such a critical role. And it talked about how poor information to a lot of the people in the community was leading to a lot of the impact of the COVID-19 in their community. So again, I think it's incorrect to say that there isn't anything we can do, because healthcare providers like yourselves can play such a critical role in making sure that people in your own communities get the right information, and information can be so important. So I just wanted to make that point, because I don't think that we aren't powerless here.
Dr. Graham, would you like to give a thought on that?
I love that comment. I saw that article too, and I'm glad you brought that up. I love it. I mean, you know, we all love Tony. I mean, I remember Tony from the flu days and Dr. Fauci from the flu days, and he is a scientist. And I think that comment was probably more said out of frustration at the moment, given, you know, an inability to really just say that there's a singular solution, because this is such a historic problem. And he's one of those folks who have been very prominent, especially around HIV and the epidemic in Black men and whatever, and has always been very strong on tackling disparities. And so I think the challenge is, you know, this is such a huge issue, and it is rooted in such long history in terms of just disparities and the kinds of things that have led our communities to have been both physically, economically, and from a health-wise isolated. But, you know, your point is exactly right. You know, with that Washington Post article, as well as some others that have come out and have said, these are the kinds of things we can do. Show me that right now is the thing to do it. And no doubt that's, again, why this NMA, if there is anyone who can help educate the Black community, are the folks who have been taking care of the Black community for a long time. The folks who are both in the clinical and healthcare settings, the folks who are in pews in terms of from engaging our Black churches. But I think that your last point in terms of bringing out an article is so true. There is a lot we can do, and NMA is right now the front line. So, you know, just now is our time in history to kind of pick up the mantle and run with it, is what I would say, to echo that earlier point.
So thank you all to the audience for your questions. To the panelists, I want to give you under 30 seconds, if you could give us a final point that you want us to take home with us, which we're already in our homes, in the face of this COVID-19 pandemic, as we're seeing our patients, most of us maybe in a telehealth format, what is the main point you want us to go home with today? Start with Ms. Megan Jacobs first.
Well, I will just say that many more young people want to quit vaping. I think it's really important to provide them with a trusted resource, one that you can feel confident in recommending. And in this era where everything, it's even more important to be digital first, digital forward, a confidential anonymous text message program is a great fit for many young people. And so I really want you to know that quitting is possible, it is achievable, and many young people would benefit from being referred to a quitting resource. So I appreciate all that you're doing to continue working in your communities during this time. Thank you.
Ms. Rubiner.
There's never been a better or more urgent time for people to quit smoking and vaping, and this COVID-19 should serve as a wake-up call to make our lungs healthier now and for the future.
Thank you. Dr. Graham.
I think we're in a historic moment, both from a public health as well as a national perspective. I think we have to use this moment to leverage as much as we can to make progress. Smoking, vaping is something that has been a scourge, both I think from a physiologic perspective on the lungs, but I think certainly in underserved communities a major issue. And this provides a point in time to tackle it. And then the last thing I'll just say is I think, the NMA, in terms of history, this is going to go down as the moment of our generation, maybe the moment of many of our lifetimes. And the NMA, the impact on Black communities, is right at the front line. So I think, working together, this is our time to, like I said earlier, just take up the mantle and move things forward.
Thank you so much to all three of our panelists, Dr. Graham, Ms. Rubiner, and Ms. Jacobs, for great presentations, discussion, and final remarks. Thank you so much to you, the audience, for tuning in today. And it is our hope you were able to take away relevant information you can apply to your practice. Do not forget this webinar has attached CME credit. To obtain this credit, please complete the post-activity follow-up evaluation, which will be sent to you via the email address you provided when you registered. This webinar is recorded and will be uploaded onto NMA's website at a later date. Please continue to stay healthy, stay safe, and stay 6 feet away from others. I now turn it back over to President Brooks for the final remarks.
Thank you, Dr. Walton, for moderating our excellent panel today. I'm feeling very good about the information shared. It was excellent. It informed us about COVID-19, the link between vaping and COVID-19, and it strayed into other areas, testing, social determinants of health, and collaboration, very important. Thank you, Dr. Graham, Ms. Rubiner, and Ms. Jacobs. This discussion has underscored to me the relevance of the NMA, and Dr. Graham, you framed that so well. For our 125th, we are learning from the past, and I will say right now, we are leading in the present, and we are launching into the future. This is one of a series of webinars hosted by the NMA related to COVID-19. Our next webinar will be on COVID-19 and HIV, scheduled to be April 25th, 2 weeks from now, same time, 12 noon Eastern Daylight Time. So stay tuned for more details. Thank you for attending. Thank you for just being a part of this movement. This is a movement, and we got to keep it moving. We cannot let it slow down. We have to have it accelerate. So I will close by saying, be well, and thank you very much. This closes our webinar.